Before I get into today's episode, I want to place a trigger warning. In today's episode, there will be some mention of suicide. If this is something that makes you uncomfortable or revives any kind of trauma, please stop listening here. If you or a loved one are considering suicide, please call the National Suicide Prevention Lifeline at 1-800-273-8255. Even if you aren't suicidal or you don't know directly anyone who is or may be, the suicidepreventionlifeline.org website has a wealth of resources to help you become more educated about the topic, and it can help you prepare should you ever have to console someone who is suicidal. With that out of the way, hello and welcome to the second episode of The Apothecary. I'm your host, Brian Kotzen. If this is your first time listening, welcome. This is a podcast dedicated to education about psychoactive substances, what they are and how they work primarily, but I also go into the history and talk about the social side of things briefly. Last week, I introduced the podcast and I talked about the history of psychopharmacology, the study of a psychoactive drug's psychoactive effects. I was really pleased with how it turned out as a pilot episode. And afterwards, I posted a poll to my Twitter to see what people would like to see covered in the next episode. I believe the four choices were opioids, cannabinoids, stimulants, and antidepressants. And an overwhelming majority voted that they wanted to see antidepressants covered. So I started doing my research and my writing pretty soon afterwards. Especially, I feel like my writing process got a little bit more efficient with the feedback that people were giving me. The main complaint that people had when I would ask them for constructive feedback about this podcast was that towards the end, I started to kind of drag on, and there were a couple, and just awkward pauses that you don't really want to hear when someone's trying to teach you something. I think it's very frustrating, we can all admit, when anyone who's doing any kind of public speaking is a speaker who just is very pause heavy, and not like a pause like they're inflecting, like a pause like they're trying to figure out what they want to say. So I kind of accounted for that, and I wrote a more complete script, so I didn't have to do as much freestyling as I did last time. But when I started doing my research on antidepressants, I realized that if I wanted to cover antidepressants, it's either going to be one very long episode that goes over a ridiculous amount, or it's going to be two episodes that are a little bit shorter and they focus more specifically on one side of antidepressants. Because, I don't want to just overwhelm my audience with a ridiculous amount of information. If I'm trying to do something remotely educational, I think the last thing I want to do is just provide an overwhelming amount of information and just have that sensory overload for my listeners. So I decided to split this episode into a 2-part series on antidepressants, uploaded within the same week, give or take. So this episode is going to focus on the history of antidepressants as a medication, and the next episode will be grounded in a more intense biological and chemical side of things. But before we really get into discussing the history of antidepressants, it's important that we understand the conditions that we use antidepressants to treat. The most obvious disorder being depression, it's in the name, but antidepressants find use as treatments for some anxiety disorders, some eating disorders, and they've even been used as treatments for fibromyalgia and similar neuropathic pains. But our primary concern is depression, because while antidepressants have found use in other areas, their primary clinical application is the treatment of depression. So depression, which is also known as major depressive disorder or clinical depression, is a common mood disorder. It can cause severe symptoms that affect emotions, thoughts, and the ability to complete daily activities like eating, sleeping, or working. So a diagnosis of depression requires symptoms to be present for at least 2 weeks. Symptoms include a persistent sad, anxious, or empty mood, feelings of hopelessness or pessimism, irritability, feelings of guilt, worthlessness, or helplessness, loss of interest or pleasure in hobbies and activities, fatigue, moving or talking more slowly, feeling restless or having trouble sitting still, difficulty concentrating, difficulty remembering or making decisions, difficulty sleeping or early morning awakening, oversleeping, appetite or weight changes, thoughts of death or suicide, suicide attempts, aches, pains, headaches, cramps, digestive problems without a clear physical cause, and digestive problems that don't ease with treatment. So that's a lot of symptoms. I realized that it probably sounded a little bit like a commercial for like a medication on TV where it's just the last 30 seconds are just the narrator just listing off all these side effects, like it may cause death, liver failure, heart failure. And you're just sitting there like, I thought this was an antihistamine, like this was an allergy medication, right? But the thing about this large list of symptoms is that it's not like everyone with depression has every symptom. Some people might. But most people, they experience a handful or a mix, not all of them. It's just that they have to be present for longer than 2 weeks. The amount of symptoms isn't really dignifying of like, oh, you definitely have depression. You have it worse than this person because you have more symptoms. No, it's treated the same. And the criteria is just the length of time that the symptoms have been present. Depression as a disorder is very individualistic. You know, it's specific to you. It's not in comparison to other people. It's your symptoms. Depression is one of the most common mental disorders, and it's caused by a mix of things. There's a genetic factor, a biological factor, environmental and psychological factors. Depression can onset at any age, but usually begins in adulthood. Depression is now recognized in children and adolescents, although it presents with more irritability than the low mood we associate with adult depression. Many chronic mood disorders like depression begin as high levels of anxiety in children. Risk factors for depression include family history of depression, major life changes, trauma, stress, and certain physical illnesses or medications. Before the 1950s, opioids and amphetamines were our go-to treatments for depression. And that would eventually stop, given that opioids and amphetamines both cause pretty heavy addiction, and the side effects just were not making it a good, useful antidepressant. And as far as natural substances go, St. John's wort has been used as a treatment for depression for years. Extracts from the plant have been used to supposedly alleviate depression, but hard clinical evidence of that alleviation, it just isn't present. The substance saw decreased use in the 19th and 20th centuries, except in Germany, where extracts were eventually licensed and prescribed. In the 70s and 80s, some small-scale tests to determine the effectiveness of St. John's wort extract were conducted, but there weren't really conclusive answers. It's still an over-the-counter supplement in most countries, but research continues on its active components, and research continues to try to understand its mode of action and how effective it is at alleviating depression. I always find herbal medicine fascinating, especially when it comes to a mental health context. I'd love to do a deep dive on a future episode and talk about herbal approaches to mental health treatment over the years. But the dawn of true antidepressants starts in 1951. Two doctors, Irving Selikoff and Edward Robitzek, two doctors at Seaview Hospital in Staten Island, New York, were conducting clinical trials on two new anti-tuberculosis agents. These agents were isoniazid and iproniazid. Selikoff and Robitzek, upon conducting the trial, noted this is a quote, "The patients exhibited renewed vigor, and indeed this occasionally served to introduce disciplinary problems." End quote. Their condition seemed to improve dramatically, and that led to a lot of excitement in the press about a promised cure for tuberculosis. Interestingly enough, if you look up Irving Selikoff, what you find is that he's the researcher who established the danger of asbestos inhalation, leading to the regulation of asbestos, and that's his primary claim to fame. When you look him up, it's a lot of asbestos and a small footnote about, he also co-founded a treatment for tuberculosis. And that's kind of weird, because that agent for tuberculosis, it sparked a lot of research into antidepressants. And I mean, a year later, in 1952, psychiatrist Max Lurie heard about the side effects that isoniazid had within that clinical trial. He would administer isoniazid to his patients, and he reported that it helped improve depression in 2/3 of his patients. So he coined the term antidepressant to describe the action of the drug. And in Paris, Jean Delay would actually report the positive effect of isoniazid on depressed patients just months before Lurie would. Delay was similarly prompted by the same tuberculosis trials. And the interesting thing about isoniazid is that we're still not completely sure how it has antidepressant effects. The speculated mechanism is that it inhibits two enzymes within the body, but that's a much deeper chemical side of things that I'll touch on in the next episode. So iproniazid, the other anti-tuberculosis agent that Selikoff and Robitzek work with, it showed a stronger stimulating effect, but there was more pronounced toxicity. So the psychiatric applications of iproniazid were assessed, and it was found to be a very powerful monoamine oxidase inhibitor. So monoamine oxidase inhibitors are a class of drug that inhibit monoamine oxidase enzymes. And those are enzymes that break down monoamine neurotransmitters, of which serotonin is the most notable. So the inhibition of those enzymes causes an increased availability of monoamine neurotransmitters because they're not being broken down by monoamine oxidase enzymes. So what this means for a depressed patient is that there's an increased availability of serotonin within the brain. Iproniazid would remain obscure until Nathan Klein came along and popularized it in the medical press. There was a huge marketing effort, and sales for iproniazid would grow until its recall in 1961 due to reports of inducting lethal liver damage. In 1957, a major breakthrough was the discovery of the antidepressant effect of a tricyclic or three-ringed compound. So cyclic compounds are a kind of compound in which a series of atoms are connected to form a ring. So a tricyclic compound is a compound of three joined rings of atoms, kind of like the Olympic rings, but minus two. So this tricyclic compound, in pharmacology, tricyclic usually only refers to heterocyclic drugs. So a heterocyclic drug has more than one element contained within its rings. So when we think about a tricyclic in pharmacology, it's a three-ring compound, and those three rings are made up of more than one element. So an example of heterocyclic, tricyclic drugs are some classes of antidepressants, anticonvulsants, and antihistamines. So antihistamine derivatives were traditionally used to treat surgical shock, and then they found use as neuroleptics, also known as antipsychotics, and these are the same antihistamines that are allergy medication, and they previously had some use outside of allergy relief. That's actually a more recent development in the lifetime of the antihistamine, because they go back primarily to the treatment of surgical shock, then they move on to being an antipsychotic medication, and from there they stem into being antidepressant medication, derivatives of them at least, not strictly antihistamine. As far as drugs that are not traditionally thought of as antidepressants go, reserpine is an antihypertensive, a drug used to treat high blood pressure, and it was shown to treat depression better than a placebo in a randomized study. And that's significant because it's the first compound to ever be truly shown as an effective antidepressant. And kind of continuing with this idea of antihistamines and antipsychotic medication, imipramine was discovered while doctors were trying to improve the effectiveness of antipsychotic medications. So imipramine was found to have an effect on depressed patients that were exhibiting mental and motor retardation. And in 1951, it began manufacturing as the first tricyclic antidepressant. In the 50s is really where we see depressants become prescription drugs. But at that time, it was estimated that only 50 to 100 individuals per million suffered from depression, or at least depression that these antidepressants would treat. So pharmaceutical companies were not keen on marketing them in favor of drugs with much larger markets. But imipramine would come to find common use, and a number of successors to imipramine were introduced. They kind of founded tricyclic antidepressants as a whole, so new successors were being developed. And we see monoamine oxidase inhibitor use increase after reversible forms of them were discovered. So these reversible monoamine oxidase inhibitors only affected the MAOA subtype of inhibitors, and that made the drug more specific to the treatment of depression, because MAOA A metabolizes serotonin, noradrenaline, and dopamine. And MOAB inhibition is typically reserved as a treatment for Parkinson's because it primarily metabolizes dopamine. In the 60s, with new knowledge about the mechanisms of synaptic transmission and a newly coined model of neurotransmitter reuptake, which of course I talked about last episode briefly, how that was introduced by Julius Axelrod. So with that newfound knowledge, researchers thought tricyclics worked by inhibiting norepinephrine uptake. But norepinephrine uptake became associated with more stimulating effects. Then the focus shifted, and we thought that tricyclics must affect serotonin. So researchers began to isolate antihistamine-derived compounds that would selectively target serotonin, and we see the dawn of SSRI medications, the selective serotonin reuptake inhibitor. So obviously the SSRI, it blocks the reuptake of serotonin, and it leads to more serotonin being present in the synapse between nerves, which leads to just an overall increase in serotonin and is a desired outcome for depression treatment. So the first patented SSRI was zimelidine, and the first that was actually released was indalpine, but fluoxetine was approved by the FDA in 1988, and it's the first notable SSRI, the first bookmark Goliath SSRI that actually saw significant use. But that just about covers the major milestones of the medication history side of things. And medication is just one route of treatment for depression. There are forms of psychotherapy or talk therapy, in a less specific term, counseling, and those can help people with depression. It's not like medication is your only option. Example of treatments for depression include cognitive behavioral therapy, interpersonal therapy, and problem-solving therapy. And those can be kind of intertwined with this medication treatment and have fantastic outcomes. But I don't really talk much about the psychological, that treatment side of things, because it's important. I just don't personally find it as interesting as something like the antidepressant treatment, or kind of the whole history of antidepressants. I find interesting how it goes back to trying to find a cure for tuberculosis, and then next thing you know, an entire class of antidepressant drugs is born accidentally. I think stories like that are really interesting, and I just don't get gripped as much by the psychological side of things, but it is very important to any kind of mental health treatment. But now that we've talked a little bit about the history, I want to talk about recent prescription trends. So in the United States in 2013, antidepressants were the most commonly prescribed medication. And as far as demographics go, about 70% of long-term antidepressant users are female. As of 2017 in the United States, about 16.5% of Caucasian people took antidepressants, and that's opposed to about 5.6% of African American people that took antidepressants. An analysis published in 2014 showed that antidepressants dispensed annually increased by 25 million between 1998 and 2012, skyrocketing from 15 million to 40 million annual prescriptions. About 50% of that increase occurred in the 4 years after the 2008 banking crash. During that time, the annual increase in prescriptions rose from 6.7% to 8.5%. That could be for a number of reasons aside from strictly the recession. Some suggestions are that the process of diagnosis for depression was improved, or that the stigma around mental health had degraded, or that some socioeconomic factors had come into play, to name a few. A major possibility leading to increased antidepressant use is their utility in treating conditions other than depression, such as social anxiety or PTSD. But as far as this episode goes, I want to end on a little bit of a serious note. In 2013, it was estimated that about 50%, half of people, did not take their antidepressants as directed. Anecdotally, I feel like a lot of people I've talked to, like it's just kind of a thing that people don't take their medication, their antidepressants. And when people fail to take their antidepressants, there's a much higher risk that the drug won't help, that symptoms will get worse, or that they miss important life events or work or are less productive. There's even the risk that the person becomes hospitalized. In general, if you are prescribed an antidepressant, it's best to stick to your doctor's instruction when it comes to that treatment. If you have concerns that your medication is not helping your symptoms, that your medication has adverse side effects, or you feel like your medication is making your depression worse, call your doctor. Have a talk with a medical professional about your treatment and whatever concerns you might have in relation to that treatment. Keeping an open dialogue with your doctor is so important. They can help you find a treatment that works for you. That's their entire job. It might take some trial and error. It might take a few different treatments, but eventually something will prove effective. With your honest input and cooperation, your doctor can find a treatment that works for you. That holds true for all medications. Talk to your doctor before suspending any treatment they may give you. Psychoactive medications are no joke. Quitting them cold turkey can do some real damage on a physical and psychological level. So please keep an open, honest dialogue with your medical professional. If you have concerns or adverse side effects, let your doctor know as soon as possible so that you can work to remedy those effects. A lot of antidepressants, just looking at it from a medical standpoint, a lot of them do not work for everybody. They are very specific drugs. I mentioned at the beginning of the episode that depression is an individualistic disorder, and it is. So when it comes to the medication, there's that aspect of individualism at play again. Not everything is going to work for everybody, so it's important to find what works for you by being honest with your doctor, cooperating, and being completely open with them about any side effects or concerns. And medication isn't the only route. I mentioned that there are therapies that are very effective, that have such high proven efficacy. So definitely just don't box yourself in and keep yourself open with your doctor and honest. And there will be improvement once you've addressed all of that. So thank you very much for listening. And I'm really excited to be continuing this podcast. Now that I'm on episode 2, it feels a little bit more real. Episode 1, it's like, yeah, whatever. You're just not going to make another episode ever again. And this is just like a diminishing pet project. I feel like I'm very prone to just kind of starting something and then dropping it, and then starting some new hobby and dropping it. But now that I'm continuing with this, I do get a lot of enjoyment after it. I really appreciate all the people who listened to the first episode, gave me a lot of really good feedback, and just in general, I don't know, this has been a really nice experience. I get to further my own interest in research, and I get to just talk about things because, I really like the format of a podcast when it comes to an educational standpoint. So I'll see you really soon for the next episode. It'll be a lot more scientific, a lot more heavy into biology and chemistry and all that fun stuff, but I'll make it as simple as I can because there's no point in kind of gatekeeping science and making it so hard to get into. So if you want to follow my Twitter at Apothecary Pod, there's going to be more updates about upcoming episodes and just kind of the process. Also, like I did for the last episode, most likely a poll so that you can reach out and put your input in as to what you would like to see next. If you have any questions, I can be reached via email at theapothecast@gmail.com. You can also send criticism there, tear into this. Just any issue you might have with the format or the audio or anything. I really appreciate criticism more than praise because it helps me make this better. And I want to give a huge thank you again to anyone and everyone who supports me throughout the development of this podcast. It's not an easy process, and I'm glad I have really good people to keep me motivated and working hard. And I'm gonna get back to working hard on the next episode now. And I will see you all very soon, hopefully. So have a good one.